Hello, everyone. Good morning, good afternoon, good evening. So we're just going to start. So, Charlie, just
Yes.
want you to let's see starting. So 6 6. Sorry for the little bit late, guys. So Charlie, our marketing specialist, we're just going to do a quickly introduction for our webinar today.
Thank you, Dr. Wilson. Good evening, everyone from Bahrain. Like Dr. introduced, my name is Shalan, and I'm from Charis Educational. And just to give you a background, maybe some of you have already heard me before from the last webinar. Charis Educational comes under Charis. We are a multi-specialty practice in Bahrain, and we focus on orthopedics, neurology, laparoscopy, ophthalmology, to name some of the few specialties that we provide. And as of 2024, we have gone into focusing with Charis Educational, providing like quality education when it comes to advancements in generally in veterinary medicine. And we have some excellent partners that we have partnered with who will be providing these programs. Like we are here today with STIF Pet Care. So just to give you a background, like most of you must have already seen, we are here for the webinar focuses on CCL disease and surgical management. And who will be speaking on it would be one among is Dr. Wilson, whom you can see on the screen. And we have Dr. Pages from STIF Pet Care also joining us. And he will specifically talk about the Z-leg technique, which would be used to get this process done. And Dr. Wilson will give you an idea about, in terms of the disease in general, like just as an overview about what happens and what can be done. And Dr. Pages will give you the technical idea in terms of how this particular ligament can be used in animals. And just to introduce, going forward, you will see Dr. Pages coming in soon. But we had in our first webinar, we had Dr. Labro, who is the founder for STIF Pet Care. We had Dr. Romain as well for joining us on the last webinar. He would also be joining us today. Also is Dr. Charis and Dr. Pages and Dr. Manhas. This comprises of this scientific committee from STIF Pet Care, followed by we have the scientific committee from us, which is Charis Educational. We have Dr. Wilson here. We have Dr. Hansel, Dr. Melvin, and Dr. Grishma. Like you would see, they are specialized in orthopedics, neurosurgery, laparoscopy, and gynecology, as well as ophthalmology and veterinary microbiology. Going forward, I will just give you an idea in terms of what we have planned for today. So going forward, we'll have Dr. Wilson starting off with the theory session. Like I mentioned, he would talk about the disease, and then goes on to Dr. Pages talking about the Z-leg technique. And I had mentioned this before in our first webinar, but for those of you who are new, we have a hands-on certification program coming up next month, which is scheduled for 24th of April. And we'll be giving you more details towards the end of the program. And if you have any questions or like you have any queries, any technicalities, or whether it is in terms of the program, please feel free to drop in the comments section your questions and we will have them answered. In case of a situation where anything isn't answered today, just while you are mentioning your question, maybe just put down your email and we will get back to you with the answer. So over to you, Dr. Wilson.
Okay, thank you. So let's talk about like a CCL disease, guys. So I try to be like a short, like this is like a subject like takes long. So just to talk about like CCL disease, probably we need more like than 3-4 hours to discuss like all like everything like it's going on. So I just try to be like short to not take too much time and give time also for Dr. Pace for talk about the Zelig technique, right? So first of all, let's talk about CCL, okay? CCL tear or CCL disease. So for sure, it's a major cause of laminates in dogs. And so everybody it's working not only orthopedic but like in general practice, we see for sure it's the major cause of laminates. Okay, dogs of all breeds, weight and age can be affected. So like large breed, small breeds, young dogs, or old dogs. So all it's very like a general disease. 4 to 6 years. So yes, it's like around that. It's quite like a hair, like a very young patients. In my experience, I can see big dogs. We see like in adult, like a young adults, so like 2, 3, 4 years. This American bully, we are seeing like a 1 year old, like a patients with CCL disease. And small patients, in my experience, I see like more like old like a patient. So I talk about like all this like poodle shih tzu. It's more like a quite normal 8 years, 9 years, 10 years old, right? Partial or like a total like a tear, total like a rupture. So let's talk about like why we can have like a partial and how to like a diagnose like on the clinical examination and to understand all this the anatomic. Just like a quick information, early neutering. I just copied from the one of the new papers that I saw. So early neutering can affect us. So I know this is being discussed in a lot like a major groups of veterinary. So early neutering can affect it, increase the chance to appear like the CCL disease in 5% of males and 8% in females, right? So we are talking about like early neutering. So usually like less than 12 months of age. Why is so like frequenting dogs compared to humans on other species? So of course, maybe on the orthopedic field, probably Dr. Page will correct me after if I'm wrong, but it's a large study in veterinary medicine. So CCL disease have been in studies and papers and lots of techniques. That's why we always bring some new techniques. Okay. What are the particularities of dogs that predispose to rupture? So why maybe in dogs is different than humans? So we are trying to understand dogs is like a chronic disease, and most of the times in the humans is caused by traumatic, right? And why is the treatment often very broad and unsatisfactory? Okay, of course, when you talk about that, it's because we know most of the techniques doesn't solve all the problems. So that's why we can have even doing the surgery, we can have some problems after that. Just a quick remember of the anatomy. So it's a primary movement, flexion, extension, of course. So you have a 121 degrees, all the amplitude. So maximum 162 degrees in extension and around 41 degrees on flexion. The principle we discuss in the clinical examination, of course, is the tibial translation. Okay, so this dislocation, cranial subluxation of the tibia in relation to the femur. And let's understand why we see that and why we can just see on the clinical examination all this movement. The CCL is the main knee stabilizer. Okay, so he can control and helps in the three main knee movements: internal rotation of the tibia, hyperextension, and cranial translation of the tibia. So the cranial advance of the tibia, right? So this is the trained knee movements regarding the cranial cruciate ligament. So the cranial cruciate ligament is it's one ligament, but two areas of insertion. Okay, so we have the caudal lateral part and the cranial medial part and the caudal lateral part. So see here in the image, in that area, we have two different insertion, two bands, okay, of the ligament. So I have like two bands of the insertion of the ligament here, like just like a color to make it a little bit easy to understand. Okay, so this bigger one is the caudal cruciate, and here is we have like the cranial cruciate ligament. So because he has like it has like two bands. It's to help like all the movement, all the like the stabilization of the joint on flexion and extension. So the cranial medial part, the cranial medial like a band, it's help like to be rigid in flexion and extension. So like all the movement of the knee, the cranial medial like a band is rigid, okay? And the caudolateral band, it's rigid in extension and losing during flexion, okay? So it's working, so see like that part of the band is more rigid on the extension. So during the flexion is losing, it's not like affecting, not working. So that's to help the cranial tibial translation to make sure like the knee is completely like stable on the flexion and extension. So the cranial medial more tension during the flexion and extension. So that's why most of the time the first like a band when you have like a partial rupture is the cranial medial band that's happened the tear. Okay, so when you have like a partial rupture, most of the time, first band that like a tear is the cranial medial. So that's why we see like the draw test on flexion, and we talk more like later to understand why you need to do the draw test and flexion and extension. But just try to remember because we have like two bands. So secondary restrictor, the CCL, so the cranial cruciate ligament, also help the hyperextension and the internal rotation of the tibia, as I mentioned before. Some cause of the CCL, cranial cruciate ligament disease. So cause of the rupture, the tear, we can have like a traumatic. So it's quite rare in dogs, of course, can happen. But most of the times when you are in front of the patient with like CCL disease, probably is caused by a chronic disease, like a degenerative disease, okay? And then we have like the biology and biomechanics can help to affect more in dogs than human. Traumatic injury, so it's quite rare, like in dogs. Usually is unilateral, so we affect like one legs, depend of the trauma, of course. So most of the time, this knee to have like a traumatic event, having some like a hyperextension or like some like a rotation, internal torsion for the tibia. So this is more like any like a trauma causing that events. So we have like acute trauma, can maybe only like a partial rupture, bring it to the total tear, or this acute trauma can like a completely like a tear or like a rupture the ligament for total. So the traumatic injury is very similar than humans. So we need to have like a hyperextension and internal rotation of the tibia. So football players is football, rugby players, soccer players. It's quite common because it's very like a normal this kind of trauma, like the picture. All right. So when you have like a traumatic injuries, again, it's really hard in dogs. Can happen the tear of the CCL. So we start in the CCL disease, and then can start the degeneration of the joint, bringing the biological factors and bringing mechanical factors as well. Just before, like I've been seeing and like talking about like the knee, like an organ, and I just like saw again the last like paper for like last year to 2023. So understand the joint as an organ. Okay, so the knee is not only like a meniscus or caudal or cranial cartilage. It's like an organ and can be affected by a complex and largely idiopathic disease. Okay, so we can call like the knee as an organ. So as an organ, it cannot be separated by meniscus, collateral ligament. So you need to try to understand like it's disease can affect it all this this like this object inside the knee, the organ. Okay. We are going to talk about like biological factors and mechanical factors. So all this like a biological and mechanical can happen and causing the tear. Biological factors, we can have inflammation, degradation, degeneration, and necrosis of the joint. Biomechanical, we have the instability. We have muscle weakness. So we have our like a TPA, so the tibial plateau angle. So like a biomechanical different than human. Our like a TPA is quite like a different than humans. Joint pressure. So we can talk about like types of exercise. Overweight patient, it's considered like a biomechanical factors for the CCL disease. So all these factors will combine like bring like together biological and biomechanical, causing like the synovitis. Okay, so the synovitis is inflammation of the joint. So it doesn't matter like if we have only like one biological factor or one biomechanical factor, one of these factors will bring the inflammation of the joint. So we can call like synovitis. Again, it's now consensus, again, the last like 2023, it's consensus the CCL disease is a multi-factor background involving local and systemic mechanics, okay? So we're starting with osteoarthritis, OA, being a key feature. Again, so it's consensus now, it's considering like multifactorial background. It's not only one trauma, it's not only overweight, not only like a one inflammation or like a secondary disease. It's like a multi-factor background involved. That's why very complex is to explain everything. What's happened to CCL? Most of the papers, one of these, why like the ligament there, or why the ligament is starting the degeneration? Because all these complex factors acting on the knee, starting like most of the cruciate ligament is composed like a collagen fibers, right? To help like the strength. So the ligament is very strange because the collagen fibers. When you have starting this degeneration of the ligament fibers become more like a fibroblast. So starting something like a chondroid metaplasia. So transforming into fibrocartilage. So instead like it has like a very strange basically like composed like of collagen fiber. So the change of the composition of the ligament and becomes more fibrocartilage. And it's bring more like a weakness to the ligament. Main triggering factor, again, synovitis that we discussed before. The synovitis, the inflammation, in some like studies, they bring like some activation of the one specific enzyme, cathepsin K. It's like when you have like any like inflammatory arthritis, this enzyme brings to the can come into like the joint and starting the alteration of the type 1 collagen, right? And then starting the degenerative joint disease, so we can know as like OA, osteoarthritis. Inflammatory arthritis brings instability. All right. So basically, like lots of papers bring it, the most of the starting the triggering starting bring the damage to the CCL is because this inflammatory arthritis. Aggressive immune response. Okay, we have like probably some immunological mechanism. So of this, like the deposition of immunoglobulins in the synovial liquid. So the synovial liquid becomes like a poor quality and transforms also type 1 collagen into the fibrocartilage. So everything like it's connected. So, this the immunological mechanism, the inflammatory mechanism, the biology, the biomechanics, everything like helps to transform the collagen type 1 into fibrocartilage. Some points to think about. Okay, this change happen in every joint. When starting all this mechanism, this complex mechanism, starting this inflammation, it's not only in one knee. So probably like all the joints, both knees, so all like another joints can suffering from some osteoarthritis. Starting of joint disease. Joint function after surgical corrections remain poor. When we talk about that, like again, we have like a lots of techniques, but we need to think like if all these techniques can help to correct 100% the function of the joint. Okay, so just like one thing to think about when you discuss about techniques. So just some important biomechanical factors. When you talk about like a joint, like in those days, we just think about the TPA angle. So that's why we have like lots of surgical options now. Only think about the osteotomies. So basically, just like bring and change the biomechanics of the knee. So just try to avoid the cranial tibial thrust. So that is not solve all the problem. That's why you need to always like think about and bring like a new techniques to try to give more back to the normal, to the anatomical way, the joint. All right. So if the function of the CCL inhibit cranial translation of the tibia in relation to the femur, okay, it's a main joint stabilizer to help with that counterposes the force of the final resultant. So basically, that's we when you like have like some factors to help the cranial tibial thrust, so the dislocation of the tibia, the TPA, overweight, the muscle extensor, and some like to help to inhibiting the factors is the muscle flexor and the crucial cranial ligament. The CCL can help like to avoid the cranial dislocation, the cranial displacement of the tibia. And the overweight, and most of the TPA like force more the CCL, and it's that's why we see like when you have the CCL tear, not only like a partial or total, we can see like this cranial displacement more because all this this force is acting on the knee based on the TPA angle. Just a quick information, the normal like a degrees, the average is 24 to 26 degrees. So the dogs like it's very like a different than humans. Humans dog is not like a 0, but they say like a 5 is maximum in humans. So it's completely like different than dogs. Of course, like I just bring like a basically what the people are like talking about all these osteotomies, but that's why we bring like a new things to think, because all this surgery, all this osteotomy can join back to the natural anatomy. So doing like only osteotomy, we are bringing back the joint like as a normal, like a like a bring before all the force, all the biomechanics. So that's we need to think about. So there is almost never traumatic. In dogs, we are talking about like a multifactorial disease. Of course, most of the time comes like a dog from to the clinic, and the owner like say, no, my dog was just like a jump from the coach and limping. So we think about no, so tear the ligament tear because the trauma, but it's not the trauma is not it just was a trigger because the ligament was sick. Probably the joint is having like some problem before, and this like the jumping or this exercise just like a help to tear the band. Understand that disease is the whole joint. Okay, so all the joints can be affected. So it's not only the cranial ligament. Have the caudal. We need to think about the collaterals. We need to talk about the meniscus. Everything is affecting. Surgery is part of the treatment of the osteoarthritis, right? And also we need to institute like starting the treatment for OA as a prevention. So we know like the osteoarthritis, the inflammation is like a base point. We need to starting like a treating before surgery, after surgery, as soon as possible. We need to treat the osteoarthritis. Quickly to talk about the meniscal injuries. So I not like point like all these the 7 like types of injuries. So just to remember, like the meniscus also not only like absorption and distribution the loads, but also helps to stabilize the joint. Okay, so it's not only like to support, but help is the joint to be more like stable. The medial meniscus is working as a secondary restrictor, right? When you have like any like a tear, a partial or total like a rupture, so a CCL disease, the medial meniscus becomes a primary restrictor. That's why, just to bring like the information, that's why the most of the problem we have on the medial meniscus, not in the lateral meniscus, when we have like a CCL disease, because after the ligament like a tear, like a rupture, the medial meniscus becomes a primary restrictor and like a suffering and get all the load more than the lateral meniscus. This is one of the most common cause of treatment failure after a CCL disease or after like a surgery. So you need to think about the meniscus. I know brings lots of discussion about how to like approach what you need to do, but just to bring idea can bring like a problems after the surgery. Preserving meniscus function decrease the chance of evolution of the osteoarthritis. So again, if you have like a functional meniscus, help a lot and they increase the chance of the osteoarthritis, the inflammation of the joint. The meniscus injuries occur at least in 20 to 8% of the cause of the CCL disease on the medial meniscus, because again he was a secondary restrictor and then he becomes like a primary restrictor. It has like a rigid insertion compared to the lateral side and relative mobility also. Caudal pole is injured by the medial femoral condyle. So basically, when you have like a dislocation of the tibia, the caudal pole of the medial meniscus is more like the absorption of the weight. It's more when you have a CCL disease. So that's why also like we have more like this damage on the caudal pole of the medial meniscus. How to check the meniscus? What's the best way? Of course, like I think in the minimal invasive, and not only like a minimal invasive, but to see like a very clear arthroscopy is the golden rule to check the meniscus. But of course, we know it's arthroscopy is not for everyone. So we have another like options. We can do a simple like a medial arthrotomy. Okay, and this medial arthrotomy can be a wide if you are just like starting on the in the knee surgery, and after we can get more practice, we start to do like a mini. So it's very like a minimal like a arthrotomy, just to check the medial meniscus, just to go into with your probe and see the lesion. So we can see on the mini arthrotomy, it's quite like a easy after like you get some practice to check the meniscus. Okay, so you need to see, of course, you need to examine the meniscus. You need to inspect with the probe to see there is a lesion. Is like there is any like a torsion. How's the meniscus? To decide after that what to do. So basically, like arthroscopy and arthrotomy on the veterinary. So it's like a quite common. Good quality MRI, like more than 1.5 Tesla. Also, it's possible to check. Ultrasound, some like very like a good like a experienced like surgeon, like a vet can also help. But arthroscopy and arthrotomy is what we are seeing like more like frequently on the vet. Okay. And just to bring like one discussion, but not for now, maybe for another day, meniscectomy. So what to do with the meniscus? We remove, you treat, we suture the meniscus now. So it's having like the few days a nice discussion on the Facebook. So it's just like to bring like a point to discuss, to bring like to what you can do with the meniscus. Important questions for me. Okay, so this is my personal like opinion. We need to check like the meniscus is firm, like in palpation. How is the meniscus? Any signs of degeneration or any signs of the lesion, and what type of the lesion? So have like different types of the lesion. Is a chronic injury or not? Like size of the dog or not? And then we decide what to do with the meniscus. Just remember, like since like 2005, have lots of papers untreated meniscal injuries, maintain laminates after surgical correction of CCL. So it's important to bring this discussion about meniscus, because like if you just like you do nothing, maybe your patient will come again with some laminates, not like recovering very well, and then we need to open again or abort again the patient to solve the meniscus problem. So you need to think about what to do. Just quickly talk about like the disease, how like to see how is like they shown to us. Okay, again, it's dogs, large and small breeds, spayed females a little bit more, obese dogs, but more like a large breeds. Dogs with any like a musculature atrophy, like old patients, small breeds, old patients. Bilateral is quite common. Okay, so it's very normal. Like we see lots of patients coming like a bilateral disease. Uncommon in puppies. So in puppies, not that common. We feel like most of the cause in puppies is by trauma. So that's why like the trauma comes more in the puppies than in adult. In the acute phase, we see like a functional impotence, like a pen, so severe limping. The dog like is changing the gravity and the gait. So we see like a very easy to see the dog like like a save the member, the limb. We see like a joint effusion, so the inflammation, the acute inflammation. So sometimes the inflammation is quite easy to see, like the patella, like a little bit like a losing, because the increase of the inflammatory, like a process, the inflammatory liquid in the joint. So after that, this acute phase, we have the chronic phase. So the inflammation more now is like a chronic. So maybe like that patient, they start to show some improvement. So the patient is like a back, not like 100%, but back to the walking quite better. We can see like in small breeds, it's quite common. Like I had some patients, when they come to the surgery, they are walking like almost very good, and they want to find out, should they do the surgery or not? You need to like explain why you need to do the surgery, even like the dog looks like showing some improvement. Okay, so you see like short step, partial support, and the most important, we see the major buttress. So major buttress is very like easy to diagnose, and you have like any patient and the clinical of this clinical presentation, the clinical history, and you see a major buttress, so you know there is some CCL disease, and probably like more than 4 weeks that happened. We see like the change of the gravity that I said to you. So the dog is like a move, like try to not using the proper leg. Okay, so you can see also the limping is quite common, quite easy to see. So I just want to show quickly. So you see like the left side, he's trying to use the leg, but it's quite like a very easy to see the limping. The sit test also, most of the dogs, when they have like any like this CCL disease, when they cannot like sit in the proper way, they need to like to bring out the knee just to avoid like the cranial dislocation and causing pain. So this is quite easy, but again, sit test is just one thing to help, but don't trust only the sit test, because some like a partial there, the dog can sit and maybe not showing the sit test. So you need to check the patient and check like a medial, not only to check all the muscle mass, but the most important, check any like a chance of the medial buttress. Okay, so you check also in the cubitus, maybe you need to sedate or not. So here on the right, you see like the major buttress, all this like fibrosis on the medial part of the knee. So when we have this because the body is trying to compensate this instability and brings all this fibrocartilage to try to help like stabilize the joint, but it's not 100%. It's not working. Drawer test, specific clinical examination. So drawer test is really good, and sometimes it's quite difficult to perform like a large dogs or obese dogs, or not quite dogs. So it's quite easy to perform. The aim is just like we are testing if we see any advanced or not on flexion and extension. So it's very important you perform on the flexion and on the extension, the movement. Why? Because I spoke before. The drawer test is very important, the extension and the flexion. If you have any partial rupture, your drawer test will be positive only the flexion. So if you perform the extension, maybe you'll not see any instability. But when you test in the flexion also, we are testing that band is supposed to be reached in the flexion. So flexion positive, it's mean we have a partial rupture. So if you need to test in flexion and extension. So if you have a positive draw test in a flexion and extension, so probably it's a completely rupture. If your draw test is positive only the flexion, so probably we are facing the partial rupture. Okay, so this is what we discussed before. So the cranial medial band is the first to tearing, and the caudolateral extend and extension. Puppies, just a quickly advice. We usually do not perform the puppy drawer, the drawer test in puppies, because that is we call a puppy drawer can bring false positive, because it's normal in puppies some a laxative of the joint, so it's quite normal. So drawer test in puppy can bring false positive, so just be careful when you're doing this test in puppies. All right. More specific test, the tibial compression test. So this mimics the support force of the limb when supporting to the ground. So this test is very the efficacy is quite high. I'm just going to show a video. It's this one, of course, is very easy to see. So just try to see the dislocation, the cranial dislocation of the tibia. Okay, just one more again. So that test, okay, again, you can perform an extension and flexion. You can perform in the medial rotation. You can perform on puppies as well. Some radiographic change. So on the X-ray, we can see some problems, some alterations. So we can see. Just remember to evaluate the X-ray. The first thing is correct the position. Okay, it's not a word you just do an X-ray with the patient low in pain, the patient moving, and just do X-ray to try to see something. No, the X-ray should be do in correct way to make sure you can see something to evaluate your patient. So do not do an incorrect position. It's not not bring to you proper information. So you need to see correct position. You need to see we see in that image, the femoral condyle is very overlay. We can see the plateau of the tibia, the condylar eminences. So we see the fibulas also to try to help to show us some information. What we can see some specific points, the femoral-tibial relationship between the femur, so the advance of the tibial by the femur. This is very for me again, it's my experience in small breeds is quite easy to see. In small breeds, I have lots of X-rays, even doing stress, and we cannot see this advance of the tibia. Because all the muscle mass is holding all the overweight. Again, so be careful in large breed dogs. Sometimes not is specific, but maybe we're not seeing. Non-specific osteoarthritis, most of the joint, we see some signs of inflammation, some increase of the infrapatellar fat. We can see like the caudal displacement of the popliteal band also. So on the X-ray, it's quite see on the left side is like a normal, like a joint. We see like the patellar tendon and the fat, the infrapatellar fat. Most of the times when you have any like inflammation of the joint starting osteoarthritis, we see like the increase of the infrapatellar fat. So it's quite easy to see if you did like a very like a good X-ray. We can see it, and then we can say there is some inflammation in that joint. The popliteal band, so it just one like a factor to evaluate to see if this tibia is more like a cranial or not. So you can see the cranial, the caudal displacement of the popliteal band, the muscle popliteal, can show help to you to see if there is any advance of the tibia. Okay, so in that image on the left side, the normal, and the right side we see the caudal displacement, the popliteal band, and also the infrapatellar fat increase. Specific look again, it's quite easy. Most of the small breeds that I saw, we see on the X-ray the cranial subluxation, right? So like the advance of the cranial of the tibia. So it's quite easy to see as we see here on the right side. Osteoarthritis signs, so the OA, so you can see like osteoarthritis on the patella, on the trochlear growth, close to the fabelas, sclerosis of the tibial plateau. So all these signs we can see, and you can say there is osteoarthritis on that knee. Diagnosis of the CCL disease, okay, so for me, like the clinical is much more important than the X-ray. So to be sure, you do not do X-ray to be sure. For me, you need to be sure like there is some instability on the clinical examination, and then you perform the X-ray to see more signs to help to bring more information to you, okay? Of course, if you have a doubt, my clinical examination, I'm not sure, the X-ray, I'm not sure, the best thing is arthroscopy. Arthroscopy is not possible. We can do exploratory arthrotomy, we can do a ultrasound, and even MRI. But MRI, to see the ligament, is better more than 1.5 Tesla. So this like a small like machine, this like an open field MRI machines will not see like a very clear the ligament. So it's better like a more like a high quality. Some key points. So for me, it's a good anamnesis. So understanding all the history of the patient, a good physical examination. For me, this is the must, should be really good. If you have any like a doubts or any like a difficulty to see this patient, sedate the patient. Okay, and compare with the contralateral. So just check it on the other side. That on the other side there is the same instability, the same like X-ray image we can see. And don't forget, quite common bilateral injuries also. A good radiographic, but make sure your position is really good. Try to do a stress X-ray to help like to mimetize the tibial dislocation, the cranial to the femur. Choice of the treatment, so it's up like to you. We have like a lot of options for surgery, and now we discuss like a new technique with the STIF pet care with the Roman and Dr. Pages. It's like we can see like a new like a technique for you guys to discuss about. Okay.
Thank you, Dr. Wilson, for this presentation.
Thank you.
It was very clear and helpful to understand more the anatomy and the biomechanics. I will do it quickly. I will just present quickly STIF pet care before giving the words to Dr. Pages to present you the technique. STIF pet care, STIF was founded in 2010 by Dr. Laboureau, which is a specialized orthopedic surgeon in human being. And during a phase of research and development. It was dedicated to it for 7 years. Mechanical testing, biocompatibility, clinical trials, etc. I will not going deeper into it for today because it's not the subject, but after this phase of research and development, the Z-League was released in 2018 under the brand STIF Pet Care, and which is a free fibers ligament we are using now quite a lot. We have more than 4,200 surgeries done around the world with good and excellent results over time. I will not going deeper into it. I will give you the words to Dr. Pages, which was one of the pioneers of the technique with Dr. Laboureau, Dr. Ledos, and he will present you the technique better than I can do.
Yeah, okay, thank you, Romain. Hello, everyone. So first of all, I will go back here to anatomy to present you the philosophy of the Z-League from STIF Pet Care. So as we already see, the philosophy of STIF Pet Care is to replace, to augment the ligament. It's not to change the way of the knee will work, because we think that nowadays most of the best techniques are to replace or to stick to the anatomy and what the nature made before. So for that, the most important part of the technique will be to implant the ligament at the place where the cruciate ligament is inserted into the bone. This article was made with a Japanese team very a few years ago, and it will help us to present to you where the roots of the ligaments are. So if you want, you can take a picture of the screen and just keep in mind these landmarks. And we will explain them to you during the technique description. I guess I will shortly give the word again to Romain, if you like, just to present the different component of the Z-League technique for the ligaments and also for the screws and the instruments.
Okay. So yes, we have the Z-League, which is the product dedicated for cranial cruciate reconstruction, caudal cruciate ligament reconstruction also. And we have several sizes because in human being, everybody have quite the same wideness of intercondylar notch and the same sizes, but in dogs it can be very different. For the weight of the dog, you can have a very big dog, tall dog, small dog. So this is why in the Z-League, as you can see on the screen, we have several models dedicated to specific weights. Then we have the L10, which is an implant dedicated to Achilles tendon reconstruction. It's the same concept. The concept is to replace the rupture tendon itself. And it can be very helpful. You can avoid external fixator or something like this. And then we have now the H-Lux, which is a ligament dedicated to, in case of hip luxation, for the reconstruction of the round ligament. About the material, it's very simple. We have one instrument set for these three uses for tendon and ligaments. I will not give you a lot of details about it. You can ask us. You can ask us after if you need more information, more precision about it. And about the screws, we have several models of screws dedicated for the ligaments and small dogs, big dogs, etc., even for cats. The color will show the diameter of the screw. So the dark blue that you can see is a 3 mm diameter. It's the smallest one that we have. We have several lenses in this model. And then the biggest one is the titanium color that you can see on the right side of the screen, which is a 6 mm diameter screw. The thread of the screws are, of course, round to not cut the ligament when you will fix it into the bone tunnels. And yes, we have also this aiming device, which can be very useful for this technique, but not only. I know that Dr. Pages, you used it for other surgeries, but it was designed for this surgery and it doesn't do magics, but it can be very helpful for the surgery. And this is on this screen, it's not very practical to see it, but I will be able to send it to you after. It's the reference chart to help you in how using, which model of drill bit using, which model of screw, key wire, screwdriver, etc., depending on the size of the dogs and the ligament you will use. This document, we send it every time to our customer once they are doing the technique. I give you the word, Dr. Pages, or you want to continue?
So, as Romain said, we have to adjust the type of the ligament to the patient. And so there are a few different materials to do the surgery, but most of the time the same implants will come back, and you will only need some exotic sizes for exotic pets. So back to the surgery. Most of the technique will be focused on the implantation of the ligament, and as I already said, the roots of the ligaments are the very important part of the implantation of the implant. So the entry point for the femur is located in the medial part of the lateral condyle, and it will be located just a bit caudal to the midway of the line, which is here in red. So it is a center of an arc or circle, which is 140 degrees. This particular point is quite hard to describe in a presentation, but what you will need to know is that it is the very center of the root of the cruciate ligament. So to perform the technique, you can do it open, or you can do it in arthroscopic control, but to start for the technique, you have to train in open technique. So the technique will start with a lateral approach or a medial approach, as you prefer, but you will need a medial patellar arthrotomy and dislocate the patella laterally. This will give you a good vision for the articular component, and the start of the surgery will be to perform the exploration of the knee. So first you need to assess that the cruciate ligament is torn, and when it's done, you also have to check for the meniscus. As we previously said, it's very important to assess for the meniscus and do some lesion removal when necessary, but if possible, we recommend to left the meniscus intact if possible. So with the joint in hyperflexion, you will be able to put a K-wire in the root of the cruciate ligament, and go to the lateral part of the femur proximally to exit this key wire. This may be possible, but sometimes you will be your vision will be obstructed by the meniscus, and in selected cases, sometimes you will have to cut the cranial ligament of the meniscus just to have better vision. But if you can not do that, it will be better. When you have to cut the meniscus, later you will have to put a stitch on it to stabilize it at the end of the surgery. An alternative will be to slide your key wire just under the meniscus and the meniscal ligament to target for the root of the ligament. When you will exit the lateral part of the femur, you will be able to have a controlled drilling of this bone tunnel. So this femoral bone tunnel will be drilled from outside to inside. This is particularly important because when you drill the bone tunnel, the drilling will create some debris, and those debris we need to have them outside the articulation and not inside. So in very few cases, if you have to do that from inside the articulation to outside, you will have to perform an important joint irrigation to remove all the debris. So this is a perioperative picture showing that the key wire is going to the proximally lateral part of the femur. And when you have performed this first tunnel, you can have a particularly angulation. We can permit you to perform the tibial tunnel. Most of the time, this angulation won't be the best angulation. Why? It's because when you enter the root of the ligament on the femur, you won't necessarily have the right angulation for the root of the cruciate ligament on the tibia. And so if you are not perfectly aligned, it will be better to do the tibial tunnel in a second time, maybe without putting the key wire in the femoral tunnel. So for that, the aiming guide, which showed Romain a few moments ago, will help to target for the tibial root of the ligament. When it's possible to do that, you can replace the motor to go back in the tibia and perform the bone tunnel. And if you need some adjustments and movement before doing the tibial tunnel, you can drill the femoral tunnel just to have some laxity in the movement. And after that, you will have both tunnels. When both tunnels are done, you will have to place the ligament inside its final place. And for manipulating the ligament, we recommend to change gloves just before manipulating the ligament. And also, when you open the sheets for manipulating the ligament, you will see that the ligament is in a plastic sheet, a specific plastic sheet that you can keep on it just to approach the ligament to the bone tunnels and never manipulate it directly with your fingers and your gloves. So it's very important to keep the ligament protected from your fingers. and also from the skin of the dog. So when you will be able to put the ligament in its final place, you will be helped with a small wire, a small metallic wire, which is bent, so this can act as a loop where you can place the extremity of the ligament. When the extremity of the ligament is in the loop, you just have to put it inside the bones and slide the ligament from one part of the other. Classically, we put it first in the tibial bone tunnel, and we slide it to the femur. When so these are the different techniques for the creation of the bone tunnels. So that's it. So when you put your ligament in place, you only have like what we call primary bone tunnels. They are oblique tunnels which connect the articulation and the bone outside the articulation. If you only put those two bone tunnels and lock the implant with the interference screws, the sliding of the ligament may be possible because the attachment will be quite weak, even if it's feeling tight at the time of the implantation. So to implant the ligament correctly, you will have to perform transverse tunnels. So those transversal tunnels are put in the femur and in the tibia. They can be just dislocated proximally and distally from the exit of the primary tunnels, like a few millimeters to 1 centimeter away from the first exits. And this is why it's called the Z-lig, as you can see. And you will be able to put interference screws in all tunnels to have a very good strength and a good locking of the implant. A few advices when you put the ligament in place. First, you have to be sure that the free fibers which are represented on this drawing are in the center of the articulation. If some knitted fibers are inside the articulation, this might create some early breaking of the implant due to friction. Free fibers of the ligament are parallel one from each other, and with time, the ligament, the previous torn ligament, will be able to have a regrowth inside and between the free fibers with fibroblast. We won't have apparently a really new ligament, but the regrowth of fibroblast will be allowed, and this will do an isolation of each fiber from one another, and this may reduce even more the breaking, the friction, and the deterioration of the implant. One very, very important part of the technique is the locking of the implant. So first of all, we have to lock the implant from one side. Most of the time we do that from the femur side, and we put a cannulated screw in the first primary tunnel, so the oblique one. All screws are put from outside to inside. So screws are not in the articulation. It's very important as well. And when you put the screw, you will have a guide for screw insertion, and this one is part of the instrumentation, and most of the time it's a hexagonal screw brooch. So after having tightened the screw in the femur, it will be important to reduce and put the ligament in a slight tension, not a real important tension, because if the implant is put into tension during any moment, with time it will evolve to a rupture. So you lock the first part of the ligament on the femoral part. You apply a small tense on the implant, and with the finger just outside the exit of the tibial tunnel, you will be able to feel if your implantation of the ligament is really isometric. This part is the most important, because if you don't have an isometric implantation, you will have one of two scenarios. The first one will be a laxity, a persistent laxity, and the other one will be a tension of the implant, which will lead to a rupture. So with this ligament in tension, you will have to perform a full range of motion, so a full extension and a full flexion. And if you feel that in some part of the range of motion, the ligament is sleeping inside the bone tunnel, the reason is that you are not isometric. If you are not isometric, the worst scenario would be to lock the implant when you will be tensed. And if you are not isometric, you have to put your ligament when the range of motion is full and possible. So you will have a small or an important laxity, a residual laxity when the surgery will be finished, but a small or moderate laxity will be better than a reduction of range of motion and a tension of the ligament. If possible, but it's not very often, you can replace the tunnels, but most of the time we are just blocked at this stage, and you have to choose to keep a residual laxity or just to stop the procedure. When you will be sure that the isometry will be okay, you can continue, and you can put the screws in the bone, the other bone tunnels, and you have this type of postoperative X-rays with all screws in place, so in the oblique tunnels and also the transversal tunnels. The red point is the femoral exit of the cruciate ligament, which can be seen here also on the right point, and with a good placement, you can see that the red point is in the center of the condylar extremity, which is represented here with a red circle. So this representation are masking the exit of the tunnel, but on the X-rays, when you have a good quality of X-rays, you can see the bone tunnels, because the titanium screw on the oblique bone tunnel is on the first part of the tunnel, and on the second part, which is close to the articulation, you will have the possibility to see this tunnel. So you can really place this red point on your own X-rays. Okay, so for the rest of the procedure, it's quite simple. You have to close the wound and perform the X-rays. I will let's Romain show some videos, and we'll talk right after that about the postoperative management.
Okay. Thank you, Dr. Pages. Alors, how I do it? Okay. Oops, excuse me. So this is a video of a dog who was operated in 2021. You saw him 3 weeks after, 2 weeks after, now 3 weeks after, and you can see he's already able to run and jump without any dysfunction on the knee. And 6 months after, it's the same story. The dog is fully operative. And I will show you another video on a cat. This surgery is also possible for cats. Of course, we don't recommend to start on very small dogs or cats because the wider the notch is, the easier it will be. But you can see that 4 weeks after, it's totally okay. The cat is able to jump to catch the birds. And yes, this is what I wanted to show you. We have a lot of post-operative videos and on our website, Instagram page, LinkedIn also. But this is an example of the results that we expect after surgery. This is to show that after the surgery, the post-operative period is very easy for the dog. Compared to an osteotomy like a TPLO, you don't have to wait for bone consolidation. You can let the dog live his life how he wants, just to be careful the 2 first weeks because of the healing process. But as the ligament is fixed with 4 screws, as Dr. Pages mentioned before, it's mechanically very strong immediately, and the dog is able to do whatever he wants. Thank you.
All right. Thank you, Dr. Pages. Thank you, Roman. So, Charlie, please just continue, just bringing more like information. Just guys, just to remember, please leave your like questions and doubts on the chat, and you can bring it here to discuss, and it will be a pleasure to answer that. Charlie?
Yes, thank you. I will come to the next part, which is in terms of like I mentioned in the beginning, we have a certified program happening next month. And I will be putting in the details of the course, which will be provided by STIF Pet Care along with us. This will be happening in Bahrain. And if you could take a moment, you could either scan the QR code that you could see on your screen, or else I have put all the details also on the chat box. You will find a link there, which you can get access to, where you can register. Just to give you an idea, the event is happening next month on April 24th. That's the plan. It's a 1-day program, and registration link in the chat box, and this QR code that you could scan. The event is happening at a place called the Crown Prince Center for Training and Medical Research, which I will come to and talk to you about it later. On the screen, you can see is the agenda that we plan to have for the day. Again, the theory session will be led by the team from STIF Pet Care. But it will be a very hands-on program, just so I will be able to explain it further when I will show the location, the venue that is finalized for this. That gives you the breakdown in terms of the morning theory session and the practical session afternoon. I can give a glimpse is that we have an animal laboratory within the center, which is fully equipped, and which would be great in terms of doing this course, because we also plan to have it on a live animal. The Zelig technique that was mentioned here earlier. We plan to do that on an animal for better practice, and it's like we have heard about this right now in theory, but let's try to put that into a practical session. So that's our aim to do next month. Next. So this is the program menu. It's called the Conference Center for Training and Medical Research. And we just recently had an event there, which was the Pet First Aid Program. Again, within the animal laboratory facility that you can see, it's the second image on the right side. That is the lab, and it's fully equipped. Now, for the first aid program, it was obviously targeted for pet owners. We don't necessarily need all the equipments. But in a program like that is offered by STIF Pet Care, it would be of great use because it has 6 stations fully equipped by COVIDian equipments. And like you can see, it's fully equipped. And the idea is that we're not just talking about this, but also practically doing it. Again, this will be in guidance with our team as well as STIF Pet Care. And so that's the facility. Now we understand that there are many of us, I can already see from the chat, they are from Italy, Pakistan, UAE, Qatar, and we would be interested to have you all in Bahrain. And to make your process smoother, we have even tied up with somebody, which is basically the Radisson Blu in Bahrain, to make it convenient. So if you go to register on the link that is shared here or through the QR code, you will end up on the registration page on our website, which will give you the guideline in terms of what is going to happen. Again, what I've mentioned here takes you to a Google form, which we have few questions to ask, and then it takes you to a payment channel. Now, once you're done with that, you will get an idea about how is it, and then you will also see there is the requirement. I mean, you will also find that the hotel details are mentioned there in terms of the rates, for how many days, and if you need any further assistance, you can always get in touch with Radisson Blu with reference to our program. So they will be happy to assist you with it. And we would obviously suggest you to enroll in it in the coming week, so that we could prepare, and then we could have you here. In terms of visa requirements, we would suggest that you visit the website as seen on the screen to make your life all easier. Like it shouldn't be too difficult. They do have everything pretty straightforward there, which will give you the guidelines in terms of what all is required in order to apply for the visa for Bahrain. So that's pretty much covers most of the things. Again, the QR code is here. Also, in addition, like I mentioned, we had a program which took place in Feb. We plan to have the next event in April, and this is just the beginning. We have more events coming up in this year as part of Charis Educational. And I would highly recommend that you would visit our website and go through the rest of the programs that are scheduled for 2024. And if you have any queries, you can always reach out to on email at education@charisvets.com, and we'll be happy to assist you with anything that is required with regards to the program. If you have even any questions in terms of your travel requirements, do let us know. We'll try our best to help you out.
All right, thank you guys. Any questions, anything, please feel free, giving 1 minute if anyone in the chat wants to share any questions. So just enjoy here, Dr. Pages, or questions for Roman, questions for Charlie, and for me. Just to see, I think we don't have questions for now.
I will do just maybe questions after. I will just do a quick reminder of critical steps, if I can say it, of the technique and aspects of the ligaments. As Dr. Pages mentioned at the beginning, it's mandatory to respect the anatomical attachment on the cranial cruciate ligament on the femur and tibia. The first step of the surgery, as you saw, is to drill a tunnel in the femur to attach the ligament in its anatomical position. This is the most critical step of the surgery. because it's here that you will be able to put your ligaments in an isometric way. The native ligament is not isometric because there are two bundles, but is placed into an isometric zone. And this is the point that we want to reach, the center of the circle. So if you respect this first step, we can say that 80% of the job is done. Then, of course, you have to stay focused on the rest of the surgery, but this is the most critical aspect. One other aspect during the surgery, as Dr. Pages said also, is to never over-tight the ligament. When you will do your drawer test, your ligament is fixed in the femur with a screw, and you will keep it between your finger at the tibial exit tunnel. You will test the full mobility, the full range of motion, and the ligament should be never over-tightened in any position. So you have to fix the ligament in the position that requires the most length during this range of motion. This is essential. And even if you are isometric, if you place your ligament in an isometric way, don't pull on it. You just fix it with a screw straight in the knee, in the articular zone, in the intra-articular zone, because as a native ligament, it's never tightened when there is no stress. It's exactly the same conditions that you should put your synthetic ligament. After, for the fibroblastic ingrowth, to favorize the fibroblastic ingrowth, it's better to, of course, the sooner you will treat the ruptured ligament, you will reconstruct it, the better it will be to favorize the colonization into the free fiber by the fibroblast. So if you have a ruptured ligament and you can diagnose it very quickly, don't wait too long to do the surgery. Because of course, after 1 month or something like this, you will have arthrosis. The remaining of the native ligaments will be very poor, very, very damaged, and it will be not as favorized as it can be at the beginning. And one last thing about the surgery, we work on an open knee in 90% of the cases. It's intra-articular surgery, so the sterile conditions have to be strictly respected because it doesn't forgive. So you have always to be very strict with it. This is why we insist on these asepsis conditions. Dr. Pages said that in the ligament, the packaging, we have a plastic sheet on the ligament to avoid any contact with the skin, with your fingers. You change the gloves when you will put the ligament into the knee, etc. This is very important also to avoid any problem after the surgery. And this was globally the big aspects of the surgery to respect. Maybe you have something to say, Dr. Pages, I don't know, but...
Dr. Pages, please, if you want to complete.
Globally, I hope we made a clear presentation, but I guess everyone seen that the technique is quite simple, seems to be quite simple and very straightforward, but it's very important to have the good good implantations of the ligaments. So practice is mandatory. You have to practice before doing the surgery on a clinical case. So I guess this will help, but you have to follow courses. It's very important.
Yes, this is how we work in Europe and over the world. As much as we can, we do workshops with vets who want to learn the technique and be able to do it on their own very quickly. Workshops are the best way to do it because you will have a specialized vet to help you. Exchange between the vets is very important, very useful. And so this is why we insist on the workshops as much as possible. of course, you can do it on your own, but workshops is the gold way to learn the technique and being sure that you will do the good things, and the vets are able to, the teachers, the trainers are able to give you all their tips, practically speaking, during the surgery on cadaver to understand it.
Yeah.
All right.
I guess that most of people know that this technique is quite old. It has been developed in 70s, 80s, 90s, but it went out of recommendation because at this time the material was not adapted. It was not good enough to last long in the articulation and last during the whole life of dogs. But now we know that we have the good implants. What we want is that the technique is well practiced, because if we solve the technique, if we sell the technique and implants to a lot of vets and the implantations are not well done, the techniques won't work. It's it's a very fine technique, and the implantation is again the most important part of the surgery.
And about it, I just want to add something. STIF Pet Care team is very close to their customers, to the vets. We help as much as we can everyone who is using the technique. So this is why when you start the technique, we ask always for the post-op X-rays, for the first post-op X-rays, for the 5-6 first cases, maybe more. It's up to you, but we always ask it for the beginning to exchange with the vets and discuss about it and improve what it can be improved. So we have good results. Vets have good results because we have to follow them and help them into the learning process, into the learning curve of the surgery. And the more you will do surgeries, of course, it has everything. The more you do surgeries, the more performant you will be. It's like bicycle, driving a car, a race car, or something like this. You have to improve each time. It's like this. And we have approximately 95% of good to excellent results, and the 5% of failures, if when there are failures, because of course it's surgeries, it happens. We explain them in all the cases, that all the failures that we had, we could explain them, and globally it's a technical mistake, not big technical mistake, but it cannot forgive sometimes.
All right. Thank you. I think we don't have any more questions, so I just want to thank you, Dr. Pages, Dr. Romain, and Charlie. Also, thank you for your time, and we see you next time, maybe the next workshop, next webinars.
Yes, with pleasure. Thank you very much for organizing it.
Thank you, everyone. We wish you all a good day, and we hope to connect with you soon.
Okay, and don't hesitate.
Thank you.
If questions are rising after it, don't hesitate to contact us. And
yes.
All right.
Okay.
Thank you. Thank you. Bye, Dr. Pages, Dr. Romain. See you.
Have a good evening
to you.
Bye-bye.
Salut, Geoffrey.
Bye-bye.
Bye.
Okay, bye-bye, Charlie. Bye, guys. See you in the next webinars. See you.